OK, donc, bonjour tout le monde, bonjour à tous et toutes. Bienvenue à cette sixième conférence déjà de la série de conférences de Montréal en éthique de la santé, édition 2023. Aujourd'hui, on a une conférence en ligne et je vais présenter notre conférencière, Dr. Cristina Richie, dans quelques minutes. Je me nomme Éric Racine et je suis directeur de l'unité de recherche en éthique pragmatique de la santé à l'Institut de recherche clinique de Montréal et aussi prof titulaire de recherche à l'Université de Montréal. Donc aujourd'hui, on poursuit sur notre thématique 2023 qui concerne la santé participative, inclusive et éco-sociale, où on souhaite aborder les liens entre la santé, la démocratie, l'environnement et nos milieux de santé plus précisément. So just to briefly explain the series to you, Dr. Richie, in 2023, we are trying to reflect on how health and our healthcare system is responsive or not responsive, actually, to its environment, both in the social science or like social sense of the term, and also its more like natural or ecological sense also. So we're kind of playing on both fronts, and different lectures are bringing us both to the social environment or the ecological or natural environment. And this is why we're bringing it into this amazing conversations, people who actually like speak to one of these issues and sometimes to both. These issues or dimensions which are obviously interrelated. And I think today's talk will be a moment where we reflect on that. So just to recap on the past two lectures, au niveau des deux dernières conférences, on a eu au mois d'avril professeur Bérard, qui est prof de sciences politiques à l'Université de Montréal et qui nous a parlé du droit d'initiative en matière de consultation publique de la Ville de Montréal au niveau de l'action collective, de la démocratie directe. Et on a vu que beaucoup des enjeux qui étaient évoqués via ce mécanisme de participation démocratique concernaient la santé publique et les liens entre l'environnement et la santé. Et au mois de mai, donc le mois dernier, on a eu droit à une conférence d'Annie Daniel Grenier qui nous a parlé de son parcours comme patiente partenaire et son adaptation aux nombreuses difficultés qu'elle a vécues lors de son parcours. Et elle a mis le besoin sur notre système de santé de s'adapter à son environnement social pour favoriser l'inclusion des personnes qui vivent notamment avec les maladies rares. So today, it is my pleasure to introduce Dr. Cristina Richie, who will speak about green bioethics and sustainable healthcare. Professor Richie is lecturer at Delft Technology University, or TU Delft. She's also joint editor for Global Bioethics, head of the Netherlands unit of the UNESCO Chair in Bioethics, and also a fellow of the Center for Bioethics and Human Dignity at the Trinity International University in Deerfield, Illinois. She will explain to us how healthcare and the healthcare industry has a tremendous impact on the environment, including in our country, Canada. In response to such concerns, she will introduce, I understand, the concept of green bioethics and its companion principles, which rely on the synthesis of environmental ethics and biomedical ethics in a way that provides a kind of interdisciplinary framework to approach the topic and the goal of sustainable healthcare. So, Professor Richie, thank you so much for being with us and accepting the invitation to speak within this series.
Eric, thank you for the kind introduction, and I'm very excited to be with you this afternoon. For you, it's 5 o'clock in Edinburgh, where I am coming to you from, so evening for me. I'm looking forward to an enjoyable time, and please, as you think of questions, as we said, we do it at the end, but you can also pop it through the chat if it's in your brain and you want to get it out. This PowerPoint slide will be made available to you after the presentation. And I'm just going to start with a background of environmental ethics. So I'm an ethicist broadly, but really my fundamental commitments to sustainable healthcare originated probably from when I was an undergrad and took a course on environmental ethics as part of my degree and really became concerned with the environment. So although my background is also biomedical ethics, and I taught previously at a medical school, and most of my writing is on healthcare and biomedical ethics, I have a strong commitment to environmental ethics in addition to other sorts of normative ethics like feminist and queer ethics. But I know not everyone's familiar with environmental ethics, so I'm just going to start by giving you a background so that we can see how environmental ethics goes over to biomedical ethics, but also how biomedical ethics goes over to environmental ethics. So the climate crisis is not news to anyone. The effects of the humans on the environment are such that we're said to be living in the era of the Anthropocene, which means instead of regular non-human movements, whereas Ice Age and such were not affected so much by human activities, now we have a dramatic impact on the climate because of human activities. So these activities release greenhouse gas emissions. One of the greenhouse gas emissions is carbon dioxide or CO2. And because we have done so many activities with so many people, we're at a critical point where sustainability is jeopardized, where we're over the 350 parts per million of safe carbon in the atmosphere. And that only speaks to what humans are concerned about. This is also destroying biodiversity, endangering plants and animals and flora and fauna that sustain us, in addition to there being a variety of other environmental issues and ethical issues that are not contained within environmental ethics. So some of these can be met today and can be acted upon to make the society more sustainable, but essentially everything needs to be rechanged or reoriented. And so this is a focus on two things. It's human population, because we're the ones affecting the environment, and resource consumption. So these are two interconnected things that environmental ethics basically focuses on, because these are the variables that we can change. Current world population has exploded. In my lifetime, it has doubled, and it's on a trajectory to continue to increase. And this is because reproduction rates are geometrical, not arithmetical. So when there's reproduction, essentially, it's not just like 1 and 1 and 1. If there's a set number of kids, 2.2 per family, then that number explodes. So world population isn't in itself morally normative, except that we're in a situation where there is competition for resources, due in large part to political structures that just take resources for the developed world and ignore the developing world, because of the kind of lifestyles that people in the developing world have, which means that their carbon footprint is much bigger. So world population includes not only new births, and there's more births than there have been ever before, but also death rate, because people are living longer again. And both of those things together impact the carrying capacity of the Earth. The carrying capacity is how many people are on the Earth using the resources in a given day or a given year. So the carrying capacity of the Earth is also impacted. It's similar to the lifeboat phenomena, is that only a certain number of people can live or live well, given the resources of the planet. Every year, the human society uses more resources than the Earth can provide by around the mid-year. So sometime around this time, you'll see a news article about, we have already consumed our resources for the year, and now we're into like our second world of, this happens in the summer. Okay, so essentially what we have is that we can have a lot of people living with a low carbon lifestyle, or fewer people living with a high carbon lifestyle, and still be situated within the bounds of sustainability. That doesn't tell us anything about justice, so we need to be concerned about that too, because it's not just an average distribution of who gets what. It's also, it's not just an average distribution assuming that everyone gets the same amount. It's not. These are unequitable. So with conversations around population growth, probably there's some red flags going off in your head around forced policies, which take away women's rights to choose if and when they reproduce. So PNAS, the Proceedings for the National Academy of Science, says, even if we were to pull as hard on the total fertility policy lever, we still wouldn't be able to address the sustainability crisis. This doesn't say what kind of policies they want to enact. So there's a variety of ways that human population growth can be reduced ethically, which is in line with other broad social commitments. For instance, we know that the more education a woman has, the fewer children she has, statistically. This is something that the UN Sustainable Development Goals has addressed in closing the educational gap between boys and girls. So if we educate women more broadly as a policy, there will be fewer people on the earth, presumably because of this factor. We also know that when there is equality between the sexes, that women have, with education also, women have more opportunities to participate in economic structures, to have a political vote, and to make a choice aside from social pressure if and when to have kids and how many. So we also know that managing social structures so that there's more equality between men and women would reduce the population. Again, the United Nations addresses this in the sustainability goals. Third, expanded access to contraception, safe abortion, and other forms of birth control would be another policy that would reduce human population ethically and have the double dividend of reducing maternal mortality and morbidity. Pregnancy kills women, and it only kills women, it doesn't kill men. Pregnancy and death of pregnant women can be avoided through contraception, abortion, and of course through safer pregnancies. So making sure that birth control is available, again, closing the gap between access and interest in contraception is something that the World Health Organization has been talking about for decades. So these are all policies that would ethically reduce human population, even aside for environmental reasons, have double dividends of supporting women and giving them more agency and autonomy, and being well set within other broad guidelines. So please keep that in mind. Secondly, we have a resource problem in that the consumption of resources leads to carbon dioxide, which contaminates the environment. So everything has a carbon footprint. This is the metric that's commonly used now. Environmental ethics used to speak about more resource use, but now carbon is a proxy for that. Everything has a carbon footprint. You do, I do, this meeting does, your glass of water does. And these carbon footprints indicate how many resources calculated in carbon emissions are being used. The average carbon footprint of an individual is based in a lot on their country. So this isn't actually like the individual themselves, it's just a statistical average. So for instance, the United States and China have the two highest carbon footprints as nations in the world. But because of the number of people who live there, Americans have about the highest carbon footprint out of any individual in the world. It was incredibly liberating for me as an American to move over to the UK and Europe because my carbon footprint dropped immediately just because of the infrastructures. So if you think in the United States, it's decentralized transportation, heavy reliance on individual automobiles, overuse of the medical industry, agriculture and meat consumption is very high. There's regular air conditioning, fossil fuel use. So all of these things are part of the national carbon footprint, which then divided by per person becomes quite significant or insignificant as it is in the EU where things are more sustainable. So the point of this slide is it's looking at the top carbon emitters by country in the world. And you can see China and US are the top two, which means that if other countries, even when other countries are sustainable, unless China and the US sign on to and actually affect carbon reduction policies, it really won't matter in terms of changing the trajectory of the climate crisis. So it's very nice that in Europe, I have a low carbon footprint, but in terms of not just me, but people who suffer from climate change health hazards, the lack of distributive justice of medical and other resources, these people are still affected because carbon emissions don't stay within national borders. So US and China export carbon, but don't take the blame or the responsibility for it. So this is an ethical problem which demands that all countries, I would say, put pressure on these two entities to be more sustainable. So that's the background of environmental ethics that I'm thinking about. I'm thinking about population growth and resource consumption. And given the climate crisis, there's two areas that healthcare has intersected with it. One is the carbon emissions of healthcare, and that's in line with environmental bioethics or green bioethics. And the other is climate change health hazards, and that's more in line with public health. So these two sides of healthcare and environmental ethics have been part of some dialogues for 20 or 30 years, and they continue today. So the first is going to be the carbon emissions of the healthcare industry. This graph has the country first. So you can see Canada is fourth down there. And then the amount of million tons of carbon that that country's healthcare industry emits per year. So it's only the healthcare industry. Then the next line is what it is per capita. So what the average individual in that country uses for healthcare carbon in a given year. And then the final column is what percentage of the country's total carbon emission comes from the healthcare industry. So we'll go to Canada. It's 29 million tons of carbon each year for the healthcare industry. What that is 0.83 per person, and it's 5% of Canada's total carbon footprint comes from healthcare. These numbers are not normatively significant unless we add some analysis to them. So what I want to do is go through the columns and bring some things to your attention. The first one is just overall carbon in a country is usually correlated to overall carbon of the nation. So if you look at China and the US, again, they have the top two biggest carbon medical footprints, and they're the top two producers of carbon in the world. So that makes sense, is that every sector would be very carbon intensive by the country. The second thing I want to point out is that per capita doesn't actually tell us who's getting the healthcare, what kind of healthcare they're getting. Is it medically necessary? Is it clinically beneficial? Are there gaps because of social determinants of health? Are there barriers to healthcare because of systemic heterosexism? So that number needs to be analyzed in terms of justice. However, I do also want to point out that there might be an idea that more healthcare carbon is better, but that's not true. So if you compare North America and you look at per capita carbon between Canadians and Americans, you'll notice Americans use about twice as much healthcare carbon on average for an individual. However, Americans don't have better healthcare outcomes measured in quantifiable things like DALYs, disability adjusted life years, QALYs, quality adjusted life years, communicable diseases, death by violence, mental health issues, et cetera. So the solution is not just more healthcare carbon for everyone. We need to look at structures that make people healthy, the kind of healthcare that's being given, whether it's carbon intensive or feudal, or it addresses a basic health need, it's preventative healthcare, et cetera. And as far as what percentage a country wants to spend its carbon on, I don't think that's really morally significant as long as everything else is taken care of. So within healthcare, as within carbon emissions, it's a zero-sum game. We're already over the 350 parts per million of safe carbon in the atmosphere. We have a limit. So actually, we need to be using less carbon each year. At the same time, there's issues of distributive justice. We know some people have very low medical standards, very low medical quality of life, and they need more healthcare to have a life where you can flourish, something like Martha Nussbaum would think about capabilities. But we also know that we can't just say everyone in the world who needs more healthcare carbon gets more healthcare carbon, because that will explode the 350 parts per million of the atmosphere. It will endanger resource use further. So what we need to do is reallocate healthcare. And that's one of the things that green bioethics looks at, which I will present soon. Note is where healthcare carbon comes from. So studies have been done in a few countries, but the NHS has NHS's UK has legally binding carbon reduction measures in place since 2009, which means they've been tracking their carbon, and pharmaceuticals are one of the top two producers of healthcare carbon. So Healthcare buildings and structures have already been looked at to be green, just as you would green a university or a cafeteria. But really, my interest is healthcare delivery, what I've called healthcare medical developments, techniques, and procedures, because that's the crux of the patient-physician relationship. That's where biomedical ethics sits, and that's what's been understudied. So keep in mind pharmaceuticals. This is similar in other health systems. So in the United States, also prescription drugs are in the top 3 most carbon intensive. So some of my recent work in The Lancet and the Journal of Medical Ethics has looked at carbon and prescribing practices of pharmaceuticals. Okay, so healthcare contributes to the climate problem. Additionally, healthcare has to take care of people who are affected by the climate. Climate change health hazards include deaths from thermal extremes, so we have colder winters and hotter summers. Weather disasters like hurricanes and tornadoes, wildfires, lightning that are intensified because of climate change, vector-borne diseases, food and waterborne infections as rain cycles change and crops get flooded, they become moldy, air pollutants, and now war. So if there's a well in a village and that's the only source of water, there's going to be conflicts over who has access to that territorially. Additionally, the last one is of note, mental health and well-being. And this isn't simply just climate anxiety, feeling sad that the polar bears are dying on the ice caps, which trivializes the climate issue. This has to do with facing unpredictable and uncertain weather situations. So a really good case study that we all lived through recently was the COVID pandemic. And there was a variety of things that are really parallel to what the climate anxiety would be like. So if you were in an area and all of a sudden you couldn't get out of town because the airline shut down, that's similar to what it's like if you are trying to get to a different city, but now there's a blizzard that has closed down the roads and the road is blocked. You can't get out. It's stressful. Another example would be if you had something like track and trace, like we did in the UK, you might have gotten a text, you've been in contact with someone who's been affected. Now you have to quarantine. Quarantining was not pleasant. People will be quarantining and do quarantine when air pollution levels are too high. So in China, there's systems where air pollution levels are high, stay indoors. This also happened recently with the wildfires in California. The unpredictability of this is where the stress comes from, is you don't know, can I go to the store to get toilet paper? Will I run out of water? When's the next climate hazard gonna come? Like, when is the next person I know gonna be infected with COVID? Are they gonna die from it? And so that is the sort of like chronic stress that comes from climate change health hazards. So that's all the bad news. And from here, I'm going to offer some pathways forward, some ethical prospects for dealing with the climate issue, with the understanding that the healthcare industry has a particular interest in addressing the climate problem because its fundamental concern is caring for those. And when it pollutes, it causes health hazards. And in the treatment of those people with health hazards, it creates more pollution. So this is antithetical to the goals of medicine and healthcare. It's counterproductive. And of course, it's bad for humans. The environmental issue in healthcare can be tackled from a variety of normative standpoints. Some ones that would be first places would be biomedical ethics, because healthcare is already familiar with that. Environmental bioethics, which has been a subset of bioethics for the last 3 decades, and green bioethics, which is the principled theory that I proposed, first published in 2013, but published in monograph form in 2019. So we're set to remember that bioethics, from the initial conception of it, was really environmentally focused. It was concerned with human ties to the ecosystem. It's a life ethic. So from that Greek, bios is life. And so biomedical ethics became a different thing many decades later. But originally in Germany and in the US, bioethics was about, it's essentially what we think about now as more like public health or One Health ethics. In 1979, the 4 principles of biomedical ethics were proposed by Childress and Beecham, and this became the standard, and the word became a little bit laconic. So now when we talk bioethics, most people think the 4 principles: respect for autonomy, beneficence, non-maleficence, and justice. So each of these we can talk about addressing environmental ethics. We can respect people's autonomy by letting them choose if and when they want to use healthcare, which is high carbon intensive, and respecting do not resuscitate orders. We can talk about beneficence and reducing carbon so that all people have better access to health because they have a healthier environment. We can talk about non-maleficence and not overtreating, because overtreatment and overuse of healthcare is bad for people and bad for the environment. And we can talk about justice and distribution of resources in terms of what is clinically beneficial instead of what people are using because it's fun or it's exciting, because that would be more of a luxury emission. Aside from biomedical ethics, environmental bioethics has looked at these 2 factors that I just brought up, the public health side and then the carbon of healthcare. And it has made, especially in the 80s and 90s, really great steps towards looking at how toxic cleaning solutions are in hospitals, at looking at green buildings of hospitals and more sustainable procurement. But it's been really superficial and generally hasn't looked at this essence of healthcare, which is the healthcare services. So environmental bioethics has done a lot to sort of green healthcare structures, but more than that, it needs to green what's inside. It hasn't done that yet. Thus, I was thinking of green bioethics as a way to more concretely look at medical developments, techniques, and procedures from an ecological point of resource impact balanced with clinical benefit, because of this concern of reallocating or redistributing medical resources in some way that's sustainable, but is also just. So, I mean, it would be sustainable to just say no one gets healthcare, but the consequence is unpalatable from an ethics perspective. So the synthesis of environmental and bioethics creates this interdisciplinary approach, and I developed 4 principles so that it is in a form similar to biomedical ethics. The first is distributive justice. So this upends Beecham and Childress, starting where they left off. The second is resource conservation. This is really firmly in environmental ethics, that we are to conserve resources, but also in a lot of policies and practices of healthcare, of using resources parsimoniously. Simplicity, which gives people agency so that they can prevent healthcare issues when possible. And then the economic side of healthcare, which would be not to put money first, but to put people first. So methodologically, number 1 is given lexical priority, but I think that they're really all intersectional. And especially when you look at extreme cases, the principles can be applied. And I chose principles instead of carbon because the metric of carbon is morally reductionistic, because we're already over the parts per million of carbon in the atmosphere, and because not everything has a carbon footprint attached to it. So we can't just say, we need to wait and get more carbon data. We need to do something, and we need a rather sensible approach to making healthcare more sustainable. So distributive justice in particular downplays respect for autonomy, not by downplaying the respect for it, but by remembering that respect for autonomy is a negative right, not a positive right. So the negative right means do not interfere. Respect for autonomy came out of World War II and the Nazi trials and Tuskegee and the Henrietta Lacks and these things where people were forced treatment that they didn't agree to, that they didn't want. And so what this principle said is you cannot force treatment on me. It's negative. Respect for autonomy was never a positive right. It's not an entitlement. It's not you go to the doctor and say, I saw this pill advertised, I want it. It's not, I'm brain dead, but my advance directive says that I should continue to have life support when there's no meaningful chance of recovery for 2 years. That's not respect for autonomy. That would be a positive entitlement, and that's not what this principle covers. So this is saying first of all, we're not going to do positive rights here for this particular thing. Of course, if it's medically necessary, people will get the treatment. But these positive entitlements are generally things that are not medically necessary. Again, like fetal end-of-life care. And it's going to look instead at justice and solidarity and saying, it might be nice for me to have fetal end-of-life care, but before I have that, because all of my medical needs are met, maybe healthcare carbon should go to the woman dying in pregnancy in Africa. Maybe my healthcare carbon should go to the child who's suffering because they can't get a broken bone set in Indonesia. Maybe my healthcare carbon would be better spent on people who have systemic barriers to basic healthcare because they're from LGBT populations. So this is saying, I'm not first, I've been taken care of, where else can we get healthcare carbon? Two is, again, we need to use resources. Medicine is good, science and progress are incredible, but we need to do this in a way where they have the most maximum benefit. It doesn't have to be maximum all the time, but in balancing this, we should be thinking, okay, as I spend healthcare carbon or as institutions distribute it, will this impact quality of life and well-being, or is it standard of living? So quality of life would be things like vaccinations, pain management. Standard of living would be like cosmetic surgery, non-reconstructive cosmetic surgery. Okay, so of course there's going to be some debate over where these lines set, but there's some broad categories that can already be set and just say, this is a want or this is a need. Third, simplicity is twofold approach. It's basically preventative healthcare and then a gradational approach to health. So physicians already use simplicity when they use therapeutic parsimony, which means that minimal tests, prevention and reversal of conditions first. And then if that doesn't work, you go through a progression of treatment. So for instance, if there's a mental health issue, perhaps anxiety or depression, the first thing you wouldn't do is a lobotomy, right? We don't really do that anymore. First thing that you would do is say, okay, what are the factors contributing to this? And can they be addressed? Can stress be managed? Can diet and eating be managed? It's not even a medical problem at this point. If it can't be, and it is in a clinical area to that level, then perhaps one of the interventions would be talk therapy or some sort of medical management that doesn't rely on pharmaceuticals. When that doesn't work, then we can think about pharmaceuticals. And if that doesn't work, maybe electroshock therapy, which is used sometimes. So you see here, there's a question of, let's go up at the level of medical and carbon intensity so that we can see if it can't be stopped earlier. Again, it's also better for people. No one wants to be sick. I don't think people really want to be in the hospital getting treatments or being hooked up to dialysis. What they want is to be healthy. And this can happen if we think about simplicity. And finally, fourth, this has been my concern with pharmaceuticals, is many medical developments and techniques and procedures are developed and disseminated based on profit. Is there money for it? So some things like sophisticated rehabilitation technologies, like a gyroscopic backpack, there's incremental benefits to users, but the potential for a large economic benefit. That also comes with a carbon price tag. So we want to think about these things where there's marginal benefit, where there's planned technological obsolescence, and look at these luxury medical goods. So if we think people first, for instance, we could think about something like the Zika vaccine, where there wasn't a huge rollout of it because people were quoted as saying it's not profitable. So this is a way that we can also address the economic side of it. So in summary, it's not just the problem of the medical industry, but we sure do have a vested interest in it. Every sector has to change. Every person has to change. Every institution has to change. I've been looking at healthcare because that's what I've studied and that's my interest. But within healthcare, we can't have environmental ethics and bioethics be distinct fields. They need to be one and the same because every medical decision has an environmental impact. And it's not just the impact of the doctor making a prescription for this patient. The patient leaves after they've gotten their treatment, they're at risk for climate change health hazards. When the physician leaves, she's at risk for climate change health hazards. And so when we think about what can we use ethically, we need to think not just what is good for me as an individual patient, what is good for the planet that sustains all of us, what is good for the person on the other side of the world who's affected by climate change health hazards and might not have access to medically necessary care, and put these two together so that we have a reoriented understanding of what we can expect from healthcare and what healthcare actually should be doing for us. That's my book, Principles of Green Bioethics, that this talk is largely based on. And those are some references, and that's my contact.
Thank you so much for this wonderful lecture and a bunch of thought-provoking and relevant ideas. And I'm hoping people will have comments and questions to explore those ideas and those new principles. I know there's already a question in the Q&A. And for everyone, if you want to raise your hand, we'll give you the mic. And if you want to formulate your question in French or speak in French, I will help with the translation. Granted that my ability to do live translation is obviously limited, but I will certainly do my best. So Q&A, there's already a question in there. I think there are two hands up, and we'll come back to you. So the question is from Victoria Dudankova, and she's asking, what would be the role of alternative and complementary medicine, which would be acting in the perspective of health promotion and readaptation of health for the individual, contrary to a collective public health vision, in reducing, what is their role in reducing the dependency of medicine and their role in fostering an ecological and less polluting vision of health. And she's giving the example of, like complementary therapies being like less polluting than synthetic drugs, for example. So any thoughts on this matter? Thank you.
Yeah, that is the question I get sometimes. And I think it's a great question because it's thinking exactly of this reorientation. So it's not going first to the technology, to the ascension to the doctor as the medical Lord. It's really looking at like, what can I do first for me, where I have control over my treatment, where it is more sustainable, and where it's probably more satisfying, I would suspect, in terms of being connected to treatment, connected to nature, and that sort of thing. So I think that it plays really an incredible role in it, especially using non-Western medicines. But the barrier there is that they're not in clinical trials, and there's a huge politics about clinical trials and what gets rolled out and who benefits from it. So functionally, I would like to see healthcare industries promote more alternative and complementary medicines through financial subsidization, and have less of a stigma around it too. Because, there is, at least in the United States, if you said, oh, I just want acupuncture or something, it wasn't really widely accepted. But again, going to respect for autonomy, if it's clinically beneficial and medically indicated, that would be the choice that you should be able to make for any reason, including sustainability, and have that respected. But I would also like to hear, discussion about this and hear from you guys what sort of complementary medicines are available in Canada with ease, and can you access them? What are the barriers?
I will let others ask questions, but there are obviously many barriers here. Being so close to the US, our system for approval and evaluation of complementary and alternative medicine is quite limited in comparison to Germany, for example. So, Madame Linda Binet, je vous donne la parole. So we have a live question now. Donc, vous pouvez prendre la parole. Je vous ai donné la capacité d'ouvrir le micro. Madame Binet? So, in the meanwhile, it seems, Madame Binet, je pense que votre micro est pas activé. Donc, je vais passer une question à l'écrit. So, in the meanwhile, I'll just go to another question formulated by Michel Stanton-Jean, who's one of our leading senior bioethicists here and has been chair of the UNESCO Bioethics Committee in the past. She's writing, congratulations, you did not make any connection between health, especially public health. I think that many of the 17 goals related to health and environment could be useful to make. It could be useful to make that connection. Could you help maybe answer this question? And I think she's congratulating you to pursue this wonderful agenda.
So the question is, what are the connections with public health?
Yes, I believe, yeah, the connections between public health and your proposal, and maybe the 17 goals are like OCDE goals for sustainable development. Yes, she's saying sustainable development goal, yes.
Mm-hmm.
So can you elaborate on the relationship between public health and sustainable health goals?
Mm-hmm.
I guess.
Yeah, they're interconnected, and most ethical theories are not exclusive in that what I presented also has firm connections with feminist bioethics. And for instance, contraception for women who want it, it has firm connections with queer suspicion of the medical industry and saying there's been a lot of times where homosexuality has been pathologized. And if there's a new medical treatment, what is it saying about our social standing? There's connections too with disability and CRIP studies, again, with this suspicion of healthcare. And suspicion of healthcare is good and essential, and we should be critical about what is being offered to us and what is the social commentary underlying it. And also know that when we accede to the medical industry, there's a carbon impact, and that impacts the person and other people. That's the public health connection. So I find that these are really non-exclusive, and almost depending on the audience that I'm talking to, I'll highlight some over another. Public health is obviously, because it's based on prevention and group, it does tend to be lower carbon. But the issue with its implementation is that most medical industries are reactive rather than proactive. So for instance, in the United Kingdom and other parts, the HPV vaccine, which can help prevent cervical cancer, is not offered for NHS patients over the age of 26, even though it's available and licensed for people up to the age of 45. So the approach is ostensibly let women over 26 develop cervical cancer and then we'll treat them instead of just giving them a vaccine. So these concepts of like, what is medicine for and what's smart, that needs to be reoriented too. So the public health approach, I think, is really will have also those co-benefits that you will see with theories like One Health or choosing widely campaigns, where it's better for populations and ecosystems as well.
Good, thank you. I will now try to give the mic to Walter Endelman. So hopefully this is going to work.
Good. Thank you for a very interesting lecture and talk and concepts and the 4 principles. With my knowledge of medical ethics, which was not overly taught when I went to medical school. My question is from Ottawa, Canada, in the province of Ontario. And the government of the day seems to be building bigger, presumably, at least according to the advertisements, better hospitals. Do you have any information about the downside of building huge hospitals rather than community-based hospitals, which obviously is closer to where the people live and they don't have to drive to it, etc.?
I don't have any information on that specifically, but off the top of my head, I'm thinking about people's individual carbon footprint and it being counterintuitive that people in cities have lower carbon footprints. So when you think about like New Yorkers, because they live in high-rise buildings, they tend to have less carbon than a decentralized detached home. So there might be some parallels there with, even though there's maybe more time to drive to the bigger places, because they can have more people stacked into one area and use the electricity in a way that's more effective. It might actually per person or per treatment have a lower carbon footprint than a community clinic, which would be standalone and have to rely on its own, like heating and electricity without the benefits of having, you know, like a neighbor who would keep your house warm. Which doesn't mean that, the thing is, like, environmental ethics can't be the #1 criteria. Because again, then it would just be, don't give anyone healthcare because we're environmental liabilities. So I think it's really important to think about this, what would be more sustainable, but at the end, the ethical aspects of medicine always need to be present, of course, and medically necessary conditions need to be treated, and we do need to expend healthcare carbon while making everything else more sustainable. Does anyone else have information on these community centers? Telemedicine's also an option for most places.
It's a good point. Telemedicine in such a large country as ours is something that was until recently rather unexplored and actually flourished during the pandemic.
Other things too, like drone delivery of medication, when that's a good way to connect healthcare with people who need it, who are in remote or isolated regions. So there's a lot of opportunities there.
So I'm just looking out to make sure to see if we have other comments, questions. So I'm going to give people maybe an extra minute to think about questions and comments before we wrap things up. But I think your lecture today very nicely bridges the two kind of brain hemispheres we were trying to connect, which was basically the social aspects of health and that the sense of the connection between the healthcare system and its kind of a ecosystem, social ecosystem, as well as the other concern we're trying to grapple with, which is its connection with the ecological or natural environment. So we were playing on those two fronts with the hope that there would be some conversations and lectures which would bring these two into communication. So I think Ring Bioethics, to my surprise, actually does a lot in thinking about the relationships between both. And we had people coming from a public health perspective also talking about the impact of the environment on health and quality of life. So the conversation is very much enriched by today's conversation. I'm seeing here another comment from Victoria, who intervened earlier in the conversation. She's thanking you for great and very grateful for your answer. She's saying there's a reflection to be held on medicalization and the ever-growing medicalization and its impact on, I would say, like on different aspects of life and population well-being, and therefore the idea of limiting or situating biomedicine's place therein is very important. She's asking maybe a question which I was also having is, what can we do with the economic context we're in? She's alluding to the contextual pressures of capitalism and the two limited discussions we have about what you call health economics, I believe, or ethical economics, actually. Which if I can piggyback on this question, to me, raises really profound questions about how can we agree to basically go in the same direction with respect to this kind of broader philosophical vision of respecting, the limits of resources, where it seems like capitalism is, I wouldn't say it's pretending, but is giving us the impression we can use individually resources without much impact on each other. So how can we develop better ideas and reflection and maybe actions with ethical economics?
The short answer is just opt out whenever possible. Just don't use healthcare if you don't need it. Consider if you really need it. If you do, ask if there's an alternative. So the topic of my third monograph, fourth book that I'm currently writing is going to be on this topic of medical sovereignty, which is essentially, once you get to the clinic, all they can offer you is autonomy. So if you think of like the Foucauldian panopticon and the sort of giving over of your autonomy once you enter healthcare, this is my primary concern. It's before you get there. Not all people have the luxury of being born healthy, and so they will need to use healthcare. So again, there needs to be a way that it's not just individuals, because the burden shouldn't be on the sick person to also be concerned about sustainability. But if you can stay healthy, don't use healthcare. If you can't, we also need physicians to have education around climate change issues, and they do. In the United Kingdom, the General Medical Council has said that part of being a professional in the healthcare industry means awareness about climate change, health hazards, and climate change, in addition to using good professional functions like limiting prescriptions if they're not necessary, looking at duplicate medications. Institutions need to be on board with carbon reduction strategies. And largely they are actually for economic reasons, because it's cheaper to not treat people, but we need to make sure we're not treating them for the right ethical reason, not because we're refusing them care. So the NHS has provided a great model. And in addition, in the Netherlands, there's the Dutch Green Healthcare Deal, which is voluntary, but over 200 companies have signed on because they get more traction and social approval by being green. So even like fertility pharmaceutical companies will have a brochure on how they care about sustainability. So how we need to get on board, I really enjoy policy, and that book proposes policies for green patients, green healthcare plans, and green doctors. But probably more likely, it's just going to need to be legislated, because if, again, US and China doesn't do anything, if medical industries don't care, the climate crisis is not going to be averted at all. And it's affecting people now, and it's affecting the most disadvantaged.
Yes. Again, this is very interesting, like as we move on in our conversation, because we're trying to broach topics related to inclusion and participation in thinking about this relationship between healthcare and its environments, social and ecological. So these ideas about how they are linked, basically, that social justice and environmental justice are linked, is something maybe we haven't really paid too much attention, but I think so far. But we're kind of obligated to realize now that these things are connected. We are currently dealing with forest fires here, like we haven't had in 100 years or so, with in public health impact and all kinds of impacts you mentioned already. So I think everywhere in the world, people are realizing that this is something we need to act on, and eventually our legislatures will have to react. And maybe if we cannot kind of agree more consensually, maybe there will have to be more dedicated legislation, as you point out. I'm looking at the time. I think we've had a number of comments and questions. Michelle Jean, who intervened earlier in the conversation, was just making a clarification. She was alluding to the 17 UN Sustainable Development Objectives. I guess I'm wondering, maybe, I don't know if you want to elaborate if there are connections between your proposal and those objectives, or if you have a critical appreciation of those objectives and their enactment by the UN and all nations.
Yeah, I mean, I think that was partially covered by a question earlier and also my comments on reducing population growth. So of course, there's problems with the Sustainable Development Goals, and many criticisms of them have been put forward. And really my highlighting that was just to say, this isn't an outlier to say like we should reduce population growth for environmental reasons. We can reduce it for a variety of ethical reasons. And so mostly with the SDGs, I've looked at climate policy, maternal care, and educational equality between men and women, because those are the ones that most tie, I think, to bioethics. And just a point that I wanted to go back to, you don't have to reinvent the wheel in terms of justice for the earth and justice for the poor. A number of Catholic encyclicals have highlighted this, and particularly because the current Pope is very pro-environment. There's an approach that they call a seamless garment, and they're just saying, look, when you destroy the earth, you impact the poor, and it's not ethical. And so anytime we have justice for the poor, it's also justice for the earth. And so you can look through that and get some principles that are broadly universal, like you don't have to believe in Catholicism to it, because it appeals to the social conscience of the individual as a thinking, rational human being, and puts those into perspective. And it is also encouraging because there are organizations like the Catholic Church that are acting on that and working towards it, even if there are, of course, other problems with the Catholic Church and institutionalized, organized religion.
On that note, I think we will conclude today. We want to thank you again for your lecture. Very inspiring as we move to the summer and are taking a break from these seminars. We have many thoughts, a lot of food for thought moving to our summer here. So I'll simply announce the next conference in French, Dr. Richie. Donc, pour tout le monde, je vous souhaite un très bel été. Notre prochain rendez-vous, c'est le 14 septembre prochain, avec un retour aux aspects un peu plus sociaux de la santé participative. On va accueillir Amandine Catala, qui est prof et chaire de recherche du Canada sur l'injustice et l'agentivité épistémique, et qui œuvre au département de philosophie de l'UQAM. Ça va être une conférence hybride, donc vous pouvez venir en personne à l'IRCM ou bien nous joindre en ligne. Et elle va nous parler de la justice épistémique dans la recherche avec les personnes autistes. There we go, and Dr. Richie, I think we have scheduled a small meeting with our group here, so we'll leave, I think, this Zoom session and join you in a separate session in a few minutes. Et pour tout le monde, je vous remercie beaucoup de votre attention, puis un bel été tout le monde. Merci pour votre participation.
Merci.
Merci.